effective to you can shift the patient to alternate day steroid. After achieving complete remission, reduce oral prednisolone to 40 milligram per square meter or 1.5 milligram, maximum 50 alternate day for 4 weeks. This is a treatment of relapse, usually infrequent. But if the patient has frequent relapses that more than 2 or 6 months or more than 4 or 1 year, so this patient with frequent relapse in nephrotic syndrome or steroid dependence require repeated course of prednisolone, often develop serious steroid toxicity. That means if the patient with frequent relapse or steroid dependence, you have to check for the signs of steroid toxicity. That is gross failure, for example, and proximal myopathy, see diabetes, osteoporosis, and to check for eyes for this cataract. Every patient with frequent relapse or steroid dependence have come to have steroid toxicity, so you have to check for that. Initial long tail alternate prednisolone serum may be used, sometimes may be used, but should be restricted to patients that do not have that steroid toxicity. Have to check for, so if a patient has steroid toxicity, it is better to shift to other agent that levomethol, cyclosporine, MMF, cyclophosphamide, MMF, and cyclosporine tacrolimus. In that order, usually start with levomethol and you can top up. For children with frequent relapse in nephrotic syndrome without steroid-related adverse effect, low-dose alternate day oral prednisolone, 0.5 milligram per kg per day alternately, can be prescribed to prevent relapse. But if the patient has steroid toxicity, better to change to other treatment. The important thing is if you want to use steroid-bearing agents such as cyclophosphamide, levomethol, and so on, it is important to initiate remission by steroid. All these other drugs will not initiate remission. Remission should be with steroid. That co-administration of steroid is recommending foreign initiation of glucocorticoid-bearing treatment. This is very important. Any treatment that cyclophosphamide, cyclosporine, MMF will not initiate remission. So you have to start steroid with them to initiate remission and then to control it. This is some summary. This perisibitol nephrotic syndrome, you have to give 2 milligram per kilogram daily for 6 weeks, followed by 1.5 milligram per kilogram for alternate day for 6 weeks. That or 60 milligram per kilogram per surface area per day, and followed by 40. The two can be used. If the patient have infrequent relapse, so you have to treat as infrequent relapse, as we said previously. If the patient has frequent relapse steroid or steroid dependence, so you can evaluate for the steroid toxicity. If the patient has steroid toxicity, start other drugs. If the patient not having steroid toxicity, you can give this prednisolone low dose 0.5 to 0.7 daily for 6 to 18 months. But if the patient relapsing on this dose, this low dose is 0.5. If the patient on this low dose in maintaining remission, is okay. But if the patient cannot maintain remission unless he has more steroid, the net day steroid, so you have to shift to other drugs like levomethol, cyclophosphamide, other drugs. So in using this alternate day steroid, there is two things. First things, the patient should not have steroid toxicity. Other things, not maintain a patient with high dose steroid to maintain remission. If you need a high dose to maintain remission, you have to shift to other. This things is late steroid-resistant nephrotic syndrome. In patients that who responding to steroid may have after that peripheral relapse dependent and may eventually stop to respond to steroid. We say it's late steroid resistant and we consider it as resistant and do the same as initial resistant, and prognosis usually is not favorable, and this patient is usually for renal biopsy. For steroid resistant, clinical guideline recommend using cyanide as the initial treatment for children for steroid resistant nephrotic syndrome. We speak about this steroid, but the important things in the management of nephrotic syndrome is the general care of the child. So besides specific therapy, you have to control edema, control infection, and management of psychosocial problem is very important because they think that this nephrotic syndrome, the family, the patient will go into CKD and so on, so on, so on. The parent should be given a detailed explanation of this order, the response to treatment and side effect of medication, along with expected outcome be provided. You have to explain the disease and the course of the disease and the treatment. It's very important to explain the side effect of steroid. Very important. The patient should know the side effect of this steroid, and the patient should know the prognosis of the disease according to your evaluation. And they have to the patient should be taught to check the urine and drugs intake to verify. Patient with the first syndrome often present with Ammar, either initially or during relapse. They may show evidence of prolonged severe protein deficiency, such as greatly reduced muscle mass and infection and so, because they are losing protein. And this is especially in the frequent relapse and dependence and resistant. So in an adequate protein intake, 2 to 3 grams per kg per day daily is recommended for them. During your administration of the prednisolone, you have to restrict salt because steroid tend to increase the blood pressure. So you have to restrict the salt, not to have high salt intake. Also, the administration of prednisolone may lead to excess weight gain and increase appetite. So fat intake should be curbed. Calcium and vitamin D supplement are required in patients with persistent heavy proteinuria because it's binding proteins for vitamin D binding proteins and other protein are lost in the urine. And the others, vitamin D, and also there's thyroxine and others carrying protein will be lost in the urine. So this should be replaced. And this usually occur in steroid-resistant nephrotic syndrome. If you use a lot of steroid, a lot of Ladix, sometimes it's Ammar, sometimes you use Ladix, a lot of doses of Ladix. So you have to make sure this potassium is okay and to correct accordingly. As I have said, depletion of hormone due to renal loss is possible cause of stunting, especially in frequent relapse, dependent, and so on. Hypothyroidism related to urinary loss of iodine proteins. Allow plasma IGF-1 and IGF-2 level aside urinary loss of carrier protein, and this will affect the growth of the child, especially the long term. Nephrotic syndrome is usually more prone to infection because of its immunosuppressive drug, because of the loss of globardine, immunoglobulin in the urine, and this is swelling and media, this is swelling and fluid, and the cracks in the abdomen, because swelling of the abdomen ascites and reduction will make some cracks in the abdomen. That makes easy introduction of the infection to the body. So they are more prone to infection. Peritonitis and cellulitis are most common. Empyema, bone and joint infection, sepsis, and tuberculosis are frequent. So they are more prone to infection. You have to guard against this. This is peritonitis, pneumonia, cellulitis, fungal infection is not uncommon, but commonly peritonitis and pneumonia and cellulitis. This should be treated before starting any steroid or such. During your treatment, you have to guard against, especially special things that is peritonitis. You have to treat peritonitis if it present. If you suspect peritonitis by abdominal pain and high fever and tenderness. Something about steroid. When to use steroid? Because suppression of hypothalamic axis is common in patients who have receiving prednisolone more than 1 milligram per kilogram daily for more than 2 weeks in a preceding 6 months. The current criteria تنطبق على patient. This patient during infection should have a steroid dose for that. If he's very ill and cannot tolerate oral, you can use hydrocortisone 30 to 60 milligram per surface area per day during stress with antibiotic, and then taper. If the patient can take oral, you can use prednisolone 0.5 to 0.8 milligram per kilogram. And this is associated with good outcome, especially in infection, and you can apply this rule to the surgery. The patient is going to have a surgery. Varicella, this is very serious because if your patient is nephrotic syndrome are receiving steroid and he has varicella or having varicella during the course of steroid is very severe and even fatal complication of the disease. So varicella zoster immunoglobulin should be administered within 96 hours of significant exposure, or intravenous immunoglobulin you can give. The exposure. If the patient develops varicella, you should receive IV cyclophorin or acyclovir, or oral acyclovir for 7 to 10 days, and the dose of steroid should be reduced during infection. Vaccination is very important. Patient receiving prednisolone at dose of 2 milligram per kilogram per day or greater, or total of 20 milligram per day or greater, if the weight is more than 10, for more than 14 days are considered immunocompromised. And this administration of live vaccine is not, it should be avoided. Until steroid therapy has been discontinued for 4 weeks. And after 4 أسابيع من توقف الsteroid, you can give live. Other vaccine better to be given on remission, or if it is important, on alternate day, because the response will be blunted. Very serious and very common complication of nephrotic syndrome with hypovolemia, especially if the patient has Ammar. And especially if the patient is treated with diuretics. And if he has diarrhea, this is a factor, very serious factor. If the patient has diarrhea, the patient has Ammar, and you are treating the patient with diuretic, they will be more prone to have hypovolemia. And hypovolemia is very serious for these children. They may complain of severe abdominal pain. If you have a severe abdominal pain, it's a sign of hypovolemia, but it's important to exclude peritonitis. So you have to evaluate the patient for poor periphery, poor capillary filling, and peripheral veins, hypotension, oliguria, heme concentration by hematocrit, and so on. Usually, in that patient with hypovolemia, you may find high urea and high low urine salt. So if this the case, you have to give fluid, and you have to give albumin. Very important to treat the patient. If he is in shock, you have to treat the shock. If severe dehydration, to correct the fluid status accordingly. And it is better to give albumin, because every fluid you give will be outside the compartment. It's better to give albumin infusion that cause fluid to be shifted from extravascular volume to intravascular volume. Careful clinical and laboratory evaluation is carried out, and volume deficit should be corrected accordingly. And this is hypovolemia in some cases may have acute kidney injury. Patient may have acute kidney injury, especially if there is infection or sepsis. Sometimes this thromboembolism is very serious, and usually patient during your treatment or so, or during the patient in the war that suddenly develop this shortness of breath, and so you have to consider pulmonary embolism. Other things, if the patient suddenly develop right or left lower vein and lower mass and hematuria, also you have to think of thrombosis of the renal vein. So thromboembolism, the short syndrome is not uncommon. So you have to consider it in any abnormal event occur during your treatment. The predisposing factor is this hypovolemia. Hypovolemia predisposes patient to thrombosis and increased blood velocity, fibrinogen concentration, a low level of antithrombin 2 and protein S, platelet hypercoagulability, and increased margination of platelet, allowing easy contact with endothelium have been observed. So there is many factors that causing this thromboembolic phenomenon, but it's very important. These two serious problems that cause pulmonary embolism and renal vein thrombosis, they are not uncommon. So dehydration should be avoided and infection should be treated. Diuretic should not be used. Diuretic to assess volume study. Very serious to give diuretics only if the patient is edematous anasarca to give diuretic. It is not good because this may cause hypotension and may cause hypovolemia and may cause all the complications they have. If the patient has if they have a thrombotic complication, you can treat with low molecular weight heparin, and you can maintain it for 6 weeks. Hyperlipidemia also is the present. The presence of hyperlipidemia upregulates the rate limiting enzyme Abshanky coenzyme detected in the liver, and there is down regulation of the lipoprotein lipase, LDL receptors, and triglyceride lipase. This change leads to increased production of lipid, a minor decrease in receptor-mediated removal of lipoprotein and lipoprotein lipase that cause hyperlipidemia. We don't need to treat this hyperlipidemia in simple cases, usually in the nephrotic in steroid dependence or steroid resistant actually. You can use drugs or the vaccine, you cannot use this. Other things, the edema. How to manage edema? Control of edema is the integral part of supportive management. Since treatment is corticosteroid usually lead to diuresis within 5 to 10 days or 2 weeks, diuretics are avoided unless edema is significant. You don't need to rush to give this edema, to give diuretics unless there is anasarca, distressing edema, and you are not keeping the patient and giving him diuretics because of this mild edema. Edema will be resolved by time after steroid taking 1 to 2 weeks and remissions occur, edema will be subsided. Don't use uncontrolled diuretics without indication. So if the patient have diarrhea or vomiting or hypovolemia, you have not to give. This is the diagram for management of edema. First, if the patient is edematous, first things you have to evaluate for volume steps. If the patient is hypovolemia, you don't use any type of diuretics. So you have to treat this hypovolemia with fluid and albumin. If the patient is not hypovolemia, you can start furosemide 1 to 2 milligram per kilogram per day, and you may need to add spironolactone, a synergistic to act in a different part of the tubule. If no response, no weight loss, and no diuresis, how to know the response? If there is no weight loss, if there is no diuresis, you can increase the dose of furosemide to 4 to 6 milligram per kilogram. If no response, you can add hydrochlorothiazide, this working the distal tubule. You have to give the hydrochlorothiazide half an hour before giving furosemide. If no response, you can give IV bolus furosemide 1 to 3 milligram per kg per dose, or you can give furosemide infusion. If you fail to control edema by giving furosemide, thiazide, and so you can give 20% albumin, 1 gram per kg IV, followed by IV furosemide, and this will cause shifting of the fluid from outside the compartment to inside the vascular compartment, and giving furosemide to decrease the fluid and decrease the level of the edema. Thank you for your attention. I hope it is very useful for you. Thank you.